Hello, and welcome to this webinar on CAR-T and CAR-NK therapies. Are they the future of lupus management? Uh, so this webinar was supported by Bristol Myers Squibb, so thank you for their support. My name is Ed Vittel. I'm a professor of translational medicine at the University of Leeds in the UK. And I'm joined today by Dr. Reuben Benjamin, who's a haematologist and clinical senior lecturer at King's College London, also in the United Kingdom. Dr. Chris Wincup, who's a consultant rheumatologist at King's College Hospital in London, also in the United Kingdom, and Dr. Marc Scherlinger, who's a rheumatologist at the University of Strasbourg in France. So although you're on mute, please do ask your questions. So we really want to hear your questions. It's always good to get through as many as we can. You can submit those anytime you think of them as you listen to the presentations, and we're going to be going through as many of them as we can at the end of all three of the talks. So here are our objectives. So the objectives of this webinar are to understand the mechanisms of CAR-T and CAR-NK therapies in autoimmunity and to explore the future treatment pipeline and emerging therapies for lupus nephritis. We want to evaluate the clinical applications and the trial designs for CAR-based therapies in lupus, and then to look at the challenges and future strategies for how these therapies could be integrated into lupus treatment. So this is our agenda. So in a moment, I'm going to hand over to Dr. Benjamin for the first presentation on oncology insights and how those might apply to lupus. And then we'll go to Chris to look at clinical applications and trial endpoints. And then finally on to Marc to look into how these therapies could integrate into lupus treatment. And then we've got a 20-minute session at the end to go through as much of the Q&A as we can. So without any further ado, I'll hand over to Dr. Benjamin. Over to you, and I'm looking forward to your talk.
Thank you, Ed, and thank you for the invitation to speak at this forum. So as a hematologist, I've been involved in the field of CAR T cells for over 10 years now, and have a significant experience now with managing patients with blood cancers who receive CAR T cell therapy. And what I hope to discuss with the audience today is really what lessons have we learned from the use of CAR T cells in hemato-oncology, so that can be usefully used in lupus and other autoimmune conditions. So, for most of you will be very familiar with the whole CAR T cell manufacturing process. And to be honest with you, over the last 10 years, the fundamental basis of CAR T cell manufacturing has not changed. And so in most cases, CAR T cells are manufactured using apheresis product from the patient. These cells are then activated. The CAR receptor is introduced into the cells, usually using a viral vector, and then expanded in the laboratory prior to then infusing them back into the patient. And what became very clear in the early years of CAR T cells in hemato-oncology was that prior to infusing CAR T cells to patients, you did need to use lymphodepletion with drugs like fludarabine and cyclophosphamide. If you did not use this, the CAR T cells just did not work. So one of the main changes that's occurred or is occurring in CAR T cells in recent years has been the shortening of the manufacturing process. It used to take up to 6 weeks or more to generate CAR T cells and then return them back to patients. But now we have rapid manufacturing protocols that allow you to generate these CARs in a very short time frame and get them into patients. And that's been hugely impressive for the hemato-oncology field. And I'm sure you'll hear more about the use of rapid manufactured autologous CAR T cells for other conditions in the years to come. So these are the CAR T cell products that are currently approved, all for hemato-oncology. The 4 of these are directed against CD19, On the left here, sorry, 5 of them are directed against CD19 and 2 of them are directed against BCMA for multiple myeloma. So the indications for all these CAR products are either high-grade lymphoma, low-grade lymphoma, multiple myeloma, or B acute lymphoblastic leukemia. And these products have been hugely successful for treating these blood cancers and are now standard of care in most countries. So how effective are CAR T cells in blood cancers? Well, this is just an example of 2 products. Tisocel, which is an anti-CD19 CAR product that has been used in pediatric B acute lymphoblastic leukemia, and over 80% of these patients respond to the product. In terms of durability of the response, well over 50% of these patients will remain in a remission, beyond a year. And now we have data going to 6-7 years following CAR infusion. So we believe that we may be able to cure about 50% of patients with pediatric B acute lymphoblastic leukemia with a CD19 CAR T cell product, which is amazing. Axicell is another product that's currently used for high-grade lymphoma. And here the results are maybe not as impressive as with ALL, but nevertheless, you're getting about 40% of patients that endure a long-term remission, potentially a cure. One of the other things, however, that did become very obvious in the early years of CAR T cells is that, there are side effects to these products. And these are some of the ones listed. And they tend to occur regardless of which CAR T cell product you use, although the severity of the complication varies from product to product. Cytokine release syndrome is probably the most commonly occurring side effect. And this occurs as a result of the CAR T cells being activated, releasing cytokines that then trigger host stromal cells to further release cytokines. And you can get this vicious loop that can be fatal if it's not terminated early. Fortunately, what we're seeing as CAR T cells are being used for autoimmune conditions, that the toxicity profile is a lot less. In terms of neurotoxicity, we had a few early deaths that occurred in patients that developed very severe immune effector cell-associated neurological syndrome. And again, this is a cytokine-mediated phenomenon. We're starting to learn about newer types of neurotoxicity, and that's commonly been termed MNTs, or motor neurocognitive toxicities. And these seem to be occurring particularly with some of the BCMA targeted therapies. And it's not quite clear what the cause of this is. It's not likely to be cytokine mediated. It may well be the CARs cross-reacting with some other antigen, or BCMA being expressed on certain neuronal cells. Cytopenias is actually quite a common side effect, and I'll have a slide that highlights the pattern of cytopenias you see following CAR T cell therapy. And then because you are targeting the B cells, you get B cell aplasia and consequent hypergammaglobulinemia. So these are some of the toxicities that you have to encounter when you're treating patients with CAR T cells. But we now know how to manage these patients. These guidelines, vary from institution to institution. We typically grade patients' cytokine release syndrome based on whether they have a temperature, whether they have hypotension or hypoxia. The lowest grades of cytokine release syndrome can be managed just with supportive care or with a cytokine blocker like tocilizumab, an IL-6 receptor blocker. But the more severe grades of cytokine release syndrome require the use of steroids, other cytokine blockers like blocking the IL-1 pathway. And shown here on the left, there's a whole series of drugs now that have been used in cases of steroid refractory CRS, which we thankfully don't see that often anymore, but every now and again you might do that, certainly in hemato-oncology. In terms of ICANS, the mainstay treatment is steroids. And again, you have to grade the ICANS based on the severity of the neurological symptoms and manage appropriately. What is important to note that if ICANS is not managed early on, the patients can deteriorate very quickly and can develop full-blown cerebral edema. And that's indeed what we saw in the early years of CAR T cells. So whilst ICANS seems to be less of an issue in the situation of autoimmune disease, every now and again you will get to severe ICANS. You do have to know how to manage that. And again, listed here on the left is a number of the novel agents that have been used in cases of steroid refractory ICANS. This sort of slide highlights the incidence of both CRS and ICANS in a variety of different trials, disease indications, and CAR T-cell products. And highlighted in the red box shows the spectrum of incidence. So in some products, you have virtually no severe grade, CRS, that's grade 3 or above. So grade 3 or above CRS would imply that the patient is hypotensive, requiring vasopressor support on the intensive care unit. But there are some products where up to 49% of the patients developed a grade 3 CRS. Again, we are fortunate that in the early data emerging in the autoimmune field, we're not seeing this sort of severe CRS. But we have to characterize every single CAR T-cell product and every single indication first to know what the safety profile of a particular CAR T-cell product is going to be. Again, with ICANS, you can see that in most cases it's less than 10% severe ICANS, but with one particular product, the Brexacel product, you can get over a third of patients developing grade 3 ICANS, where their neurological state is compromised enough to be on ICU, potentially needing ventilation to protect their airway. So shown here is a pattern of cytopenias following CAR T-cell treatment. Most patients following lymphodepletion will get a drop in their neutrophil counts. And in all cases, and that typically happens within the first 7 to 10 days. Then you get a recovery in the blood counts by about day 14 following infusion. And then you get a second dip in the neutrophil count. And in about a third of patients, that rapidly resolves. But in another kind of third of patients, you get this ongoing intermittent neutropenia that requires ongoing doses of GCSF. And then in a smaller proportion of patients, about 20 to 30% of patients, you do get more severe cytopenias. This is all data in CAR T cells and hemato-oncology, but it could still occur even in the autoimmune setting. I don't think you do. And in this more severe cytopenia setting, you have to do additional things like alpha-thrombopang or steroids, or in some more severe cases, stem cell rescue. So infections is another thing that you have to really kind of deal with, because most of these patients will have had flu-side lymphodepletion, their B cells will have been depleted, and they have hypogammaglobulinemia. So we do routinely use antivirals, antifungals, and antibiotics. We have to concurrently manage CRS with antimicrobials, because you cannot sometimes tell the difference between the two, and both may occur together. And you have to proactively use GCSF to manage neutropenias. In many cases, we give prophylactic immunoglobulins, sometimes starting as early as a month after CAR T-cell infusion, and in some cases going on till about 12 months before you get natural recovery of immunoglobulins. And we do tend to try and minimize the duration of steroid treatment that is used, for instance, in managing CRS and ICANS, to again reduce the incidence of infections. Now, what did, however, become obvious in the early years of autologous CARs is that there's some patients we could not generate a CAR product for them. In some patients, the period between apheresis and infusion was too long, the disease rapidly went out of control. So the field started to look at alternative supply of CAR T cells, the so-called allogeneic off-the-shelf CAR T cells, where they're manufactured from a healthy donor in advance and then used as and when needed. And the idea behind this is that you have a treatment that's available straight away. You can standardize or validate these cells, unlike with an autologous CAR, where what you get, you have to infuse. Whereas with an allogeneic CAR, if you don't get a good enough batch, you can discard them and start again. And potentially you get economies of scale, reduced costs, potential for multiple infusions. And because you're deriving cells from healthy donor T cells, they may be more efficacious than from cancer patient-derived CAR T cells. But the biggest obstacles are obviously graft versus host disease and graft rejection, as these come from donors that are not matched with the recipient. So what the field did very early on is looked at ways of overcoming this GVHD and graft rejection. This is a schematic diagram showing, one of the possible strategies, and that's to take T cells from a healthy donor, to introduce the CAR in the usual way, and then to knock out the endogenous T cell receptors. And this has been done with various gene editing tools, TALENs, CRISPR-Cas9, and base editors. And so in theory, this product now no longer has an endogenous T cell receptor, so it could be given to any patient. And I was fortunate to lead one of the early trials using an allogeneic CAR T-cell product called UCAR19. And this was exactly using such a strategy of editing out the endogenous T-cell receptor using TALENs. And we treated patients with adult B-acute lymphoblastic leukemia. And these were the results of the study that we published a couple of years ago. And overall, about 48% of the patient did respond, shown in the green bars here. So that's actually pretty good. However, what was less good was that the number that then remained in remission was not that high. So only 29% remained in remission at 6 months. So the majority of patients were relapsing early. And the reason for that, well, these CAR T cells were being rejected by the recovering host immune system. So certainly in the cancer setting, we need to have persistence of CAR T cells in order to get a durable effect. Nevertheless, we were able to demonstrate that it was feasible, it was safe to adopt this approach. And then people started to look at other allogeneic platforms, not just T cells, but introducing them into NK cells, into gamma delta cells, into another, rarer cell type, the invariant NKT cells, or indeed generating them from iPSC-derived cells. And I want to just briefly highlight data from one of the early allogeneic CD19 CAR NK cell trials. And this was done in patients with CD19 positive B-cell malignancies. This was done at the MD Anderson by Katie Rizwani's team. And in this study, patients were given allogeneic CAR NK cells targeting CD19. They were also transduced to express IL-15 in order to try and improve the persistence of these NK cells in the patients. And you will see that about 30% of patients had a durable remission, which is actually pretty good. And it's probably the best results we've seen with CAR NK cells in B-cell malignancies. If you look at the toxicity profile shown on the right here, there was hardly any severe grade CRS. In fact, we only had one grade 1 CRS of the, I think it was 40 odd patients treated, no graft-versus disease, no neurotoxicity. And so some might say that an NK cell-based strategy would be much safer than a T cell-based strategy. However, my own personal view is that certainly in the cancer indication, that is yet to be proven, because you do need persistence of these cells. But maybe on an autoimmune setting, that may not be as important, and perhaps that might be just as good. So shown here is the B-cell aplasia that you saw in that study following CAR NK cell treatment. And although the majority did get B-cell aplasia, you're getting recovery of the B cells as early as 2 months. That might ultimately lead to then failure of this therapy in this indication. So these are some of the lessons we've learned in hemato-oncology, that you do need lymphodepletion for activity of the CARs. The toxicity is influenced by tumor burden and the product type. Earlier and more aggressive toxicity management results in reduced morbidity and mortality potentially. We've also observed that CD28-based CAR T cells show a rapid early expansion and potentially more early toxicity, whereas 4-1BB-based CARs, which are actually account for the majority of the newer CAR products being generated, show greater persistence. There is a trend towards treating the disease earlier now in cancer because you're collecting fitter T cells. And certainly in the allogeneic setting, we are seeing encouraging response rates, but perhaps less durable responses, at least in the cancer indication. And the other kind of major thing that we learned when we were treating patients with CAR T cells is the relevance and importance of the multidisciplinary team, from the neurologist to infectious diseases specialist to intensive care specialist. And I think that was critical, to deliver this treatment safely. And if I just sort of flip briefly to its relevance now in autoimmune disease before I hand over to my rheumatology colleagues who will discuss this in more detail, it became obvious very early on that certainly if you could target your B cells effectively with a CD19 CAR, why not use it to target autoimmune conditions where you get autoantibodies being generated? And nevertheless, it took until 3 years ago that George Scheck, the rheumatologist in Erlangen, to actually take that bold step of repurposing these CARs for autoimmune disease. And so you can actually target B cells in the standard way, or you can generate a CAR specifically against the autoreactive B cells. And that has also been done. Another way of targeting autoimmune disease using T cell-based therapies is to put a CAR into regulatory T cells. which will then dampen down the autoreactive T cells that might be present in autoimmune disease. But the biggest successes come from simple CD19 CAR T cells in autoimmune disease. And this is the initial study that led to this amazing kind of results in Erlangen. And what I have shown here on the right is the list of diseases where there is now evidence that CD19 CAR T cells can work in the autoimmune disease setting. So shown in red are all the rheumatological autoimmune conditions, shown in blue are all the neurological autoimmune conditions, and shown in black are all the hematological autoimmune conditions. And most of these are currently case reports or case series. The proper kind of registration studies are underway for many of these conditions, and we're really excited to see the kind of final results of them. One question that remains for the field is, what is the best target for CAR T-cell therapy in autoimmune disease? CD19 is generally what's been used so far, but BCMA may also be a good target, or perhaps you target both of those, and there are CAR T-cells that can target both antigens. Some have tried to target the BAFF receptor, and I put down desmoglein 3 here, and that's a particular autoantigen that is relevant for an autoimmune condition called pemphigus. And there are now desmoglein 3 targeted CAR T cells that have been shown to be effective in mouse models, and the clinical trials are now underway. So I'm just going to end by throwing out some questions which still remain in the autoimmune CAR T field, and perhaps this can be discussed after my next two speakers talk. First of all, how durable are the response likely to be in autoimmune disease? Can they be curative? Is the safety profile likely to be similar regardless of which autoimmune condition you target? We've already talked about what best target might be. And importantly, can allogeneic CAR T cells be used as effectively as autologous CARs in autoimmune conditions? I've kind of suggested that maybe in cancer, currently, allogeneic CARs are not as effective, but perhaps that might not be the case in autoimmune conditions. And how does one deliver autoimmune CAR T cell trials and hopefully eventually license products for autoimmune conditions? It's a massive undertaking to be able to do this, and healthcare systems globally will need to respond to this. Will we need to create very specific cell therapy centers and have cell therapy specialists trained to give CAR T cells to a range of different conditions, rather than use the hematologists that are currently the main ones giving CAR T cell therapies? And then will, however, bispecific T cell engagers be as effective as CAR T cells? If they are, then perhaps they will replace CAR T cells. I think the jury is still out on that. And then as a final thing, should one or more of these CAR T cell products become approved for autoimmune conditions like lupus, how will healthcare systems, even in the Western world, ultimately be able to afford that? But I suppose in a way that's a nice sort of thing, a nice sort of option to have a licensed CAR T cell product for lupus or other autoimmune conditions. I'll stop here. Thank you.
Thank you very much, Reuben, for that overview. It's just incredibly useful for us to hear from somebody who's been working in the field for so long and has so much experience in leading these studies. And I already thought of lots of questions of my own that I'll come to at the end. But before we do that, it's time to hand over to our next speaker. So I'll hand over to Chris Wincup. So we all know that doing the clinical trials in this field has been difficult, and I think one of the people that a lot of us are looking at with envy is Chris, who seems to have been good at getting them off the ground. So maybe you can let us all know the secrets there.
Thanks very much, Ed. Really appreciate the invitation. It's great to be here. It's also great to follow on from Reuben, who has been instrumental in allowing me to understand about CAR T cell therapy on the day-to-day here at King's, particularly as we try and set up a number of these studies. There we go. So these are my disclosures. I think perhaps the main ones are that I'm involved in a number of these trials, and also Reuben and I have received some funding together to look translationally at CAR T cell therapy in the lab here at King's in lupus as well. So as Reuben has very kindly pointed out, this is a schematic showing the overview of CAR T cell therapy as we currently understand it from an autologous perspective. I think that as a rheumatologist, we are over on the left side of the screen at the moment, where we're trying to find patients to put into studies. And a lot of what I'll try and cover in today's talk will be which patients, how, when, why, and perhaps challenge what we're currently doing. Once we find these patients, it's important to liaise with our colleagues in hematology, as they have vast experience of the other steps as we progress further right across the screen, as Reuben has very kindly identified. But from my perspective, I think that it's important that we're involved in all steps of this, especially as we start to think about consenting patients to these studies. So I think that a good place to start is building on what Reuben mentioned, and that was where we had this initial data presented from the German group in Erlangen, with the first few patients treated with cellular therapies, CAR T-cell therapy for severe and active refractory lupus. So it's interesting where the time has gone since this first happened, what's happened since with a number of these trials and further discussions. But thinking back to what was done, this was a fairly standard CD19 derived CAR, looking at that was using both CD4 and CD8 positive T cells. And the CAR was introduced via a lentiviral vector, which Reuben mentioned as relatively straightforward and standard for the treatment in hematological disease. Now, here I've summarized the first 5 patients that were treated, and it's really important to remember here that this was an open label study. This was not done as a clinical trial. The selection of the patients here were defined as those who had exhausted multiple treatment options and had severe and refractory disease. And I think there's a few things to talk through on this slide when considering what we're doing in terms of setting up clinical trials, selecting patients, and who's coming into these studies. So for a start, these patients were all generally quite young. And they had quite a short disease duration with a maximum of 9 years, but many patients between 1 and 4 years. If you look at patients 1 and 2, you can see they had very active disease with SLEDAI scores of 16. So for anyone who's perhaps less familiar with this in the audience, these are patients that had quite active lupus. You get into many studies with those scores. And then interestingly, patients 4 and 5, so the later patients treated had SLEDAI scores of 8 and 9. And from a UK perspective, we wouldn't hit threshold to give these patients belimumab. So it's interesting that these patients then went into CAR T-cell therapy trials. And I would speculate that this is probably showing that those initial sick and refractory patients did quite well, and perhaps the therapy was found to be fairly safe, and therefore the threshold was reduced. If we look at organ involvement, and again, thinking about clinical trials and where people are setting up these studies, all of the patients had some degree of proliferative lupus nephritis in the past, in addition to a number of other manifestations, predominantly involving skin, lungs, joint, and cardiac involvement. Again, with this being a study in Germany and thinking about things from a UK perspective, only the first patient had received B-cell depleting therapy with rituximab, but belimumab had been used in all of the other cases. So other forms of B-cell targeting treatment had been used in these patients. And I'm sure in many cases we could agree that these patients were probably what we would define as clinicians seeing patients with lupus as severe and refractory cases. The data was presented, and subsequently there have been further patients enrolled into these open label studies. And so this is just the data from 8 patients. Many of these patients were at 6 months follow-up, apart from patient 8, who's reported at 3 months. And you can see here broadly what has been mentioned to many people, and many people are aware of when thinking about CAR T-cell therapy. So in terms of response, DORIS remission was seen in all patients. And the way I like to describe this to patients or people who are perhaps not involved in lupus studies is, if you had suggested hitting a DORIS remission in a lupus trial, you are probably risking that trial not working in many cases. If you're saying you're going to do that relatively early at 3 or 6 months, I think that eyebrows would have been raised before this. And similarly, if you were to say patients were going to come off all concurrent therapy, I don't think anyone would have believed it possible. And I'm not saying this to overemphasize the results of this open label data, but more to frame the fact that when we're thinking about clinical trials, we do have to think about the endpoints and what we deem to be acceptable in a very different way that we would compared with when thinking about our standard monoclonal antibody therapy trials that we're all very used to doing. SLEDAI scores here were 0 in all patients. You can see generally quite well tolerated. There were no high-grade CRS, and just building on what Reuben said, that many of the open label data and early data that's being reported shows low-grade CRS, and no ICANS was observed in this group. So again, perhaps suggesting safety and tolerability that needs to be really expanded out into much larger studies before we really understand whether this is a safe and effective treatment. So thinking about phase 1 studies, and a number of these have been set up and reported, and thinking initially about the autologous field. So this is some data from a phase 1 study, again, open label, very hard to blind or randomize in this study. And this was 9 patients, of which 4 had been treated with the so-called next generation autologous CD19-directed CAR T-cell therapy. So the kind that we're all fairly used to hearing about and thinking about what Reuben was mentioning. These are slightly more advanced in terms of the way that their constructs are designed. Now, these patients all had active lupus nephritis, and that was defined as a BILAG A score. In terms of safety, there was 1 grade 1 CRS and no evidence of ICANS. So again, building on that data from the German group. But I think the important thing to say here is, in terms of the outcomes, all patients discontinued their therapy. Again, we wouldn't usually be thinking of that in terms of lupus studies. Most SLEDAI domains improved, and you can see this here in the graph, that we don't hit 0 in all of those cases. There was improvement in proteinuria, but not full resolution of that proteinuria within the short follow-up period of this study. And therefore, we don't see SLEDAIs of 0, and I would suggest that we don't panic about this. We never would be aiming for a score of 0 at such a short interval. And that data from Germany really, really is very interesting. But we need to think about clinical trials, and we'll find a lot more data from here. So we should not be too disheartened if people are not getting their SLEDAI down to 0 in such a short period of time. But the longer term is going to be what's really important here. And then thinking about what happened in terms of the B-cell aplasia, well, B-cells returned within between 3 to 6 months. And predominantly these were of a naive phenotype with a marked reduction in plasmablasts. So mechanistically, perhaps telling us a little bit about why these therapies may be working differently to our standard monoclonal antibody therapies. And as was mentioned in the previous talk, it depends what you're targeting. And obviously, we're all used to CD19, CD20 targeting treatments, but the plasmablast compartment is also important, in particular when we think about CAR T-cell therapy targets, what antigen is being looked at, with BCMA obviously being under investigation and used in the myeloma cohort. So let's see if there's further data. Well, this is another autologous study looking at CD19-directed CAR, again for lupus nephritis, again open label, very similar, but produced by a different company. And you can see here an initial readout of the patients treated here. What we can see is that there are a number of different patients here who had received a whole mix of different therapies in the past. So again, how do we define refractory lupus? Well, there's multiple therapies used there without full response. And so these patients were treated with varying levels of cells. And again, this perhaps goes back to the point that was discussed earlier. The amount of cells that you get back following apheresis may be variable. And you can see here that, again, there was a good result in many patients, albeit some of them under short follow-up. But one patient did need to restart their concurrent immunosuppressive therapy with mycophenolate at 6 months. So again, we see the impressive data from Germany, but the clinical trial data is going to be important here. I would argue that we shouldn't be aiming for all patients to have full response all of the time. I don't think there's any drug that will give 100% cure rate 100% of the time. And it would be foolish to think that we would get that drug in lupus. So we know that it's working well for many patients, but some patients are only getting a transient response. And we need to better understand that, particularly as we think to advance this through the phases of more clinical trials. So this was the first few patients in the trial, and also a named patient access scheme, very similar to that used in Germany. And serological improvements were noted. But again, there was this one patient who relapsed, and it was suggested that maybe the patient had a slightly higher BMI, that their cell count may have been slightly lower than they needed for their body weight. I don't think we can draw any firm conclusions on the basis of a handful of patients treated, but this is going to be really important when we think about this progressing down the line in the future. As was outlined, allogeneic has been looked at in hematology and may be an option in rheumatology. And this is, again, a readout of some data from allogeneic CAR NK cells in 20 patients with active and refractory lupus. Now, a very different approach this to the CAR T-cell therapy, where patients required 3 infusions of the treatment. But again, as this is allogeneic, it's probably slightly more easy to deliver than patients going through 3 autologous CAR T or CAR NK cell therapies. And the readout of this study was, again, at 12 months, focusing on safety and efficacy. And in terms of efficacy, those endpoints of DORIS and LLDAS were included. Again, looking at this graph, you can see that many patients do go in the right direction, that there is an improvement in terms of their SLEDAI score and their physician global assessment score, but not in all cases, and in some cases not maintained. Biologically, the B cells reconstitute within 2 to 3 months. Again, it was low-grade CRS with no other adverse events. This is a relatively short period of follow-up, with 50% of patients achieving a DORIS remission and 75% achieving LLDAS. So these are still good results, but I think it's important that we use this as a reality check to say that we're not going to see every single patient come off treatment and go into remission within 3 months. We would be foolish to think that. And this is what's really coming out in this data. Similarly, this is an allogeneic CAR-NK cell therapy. So we need to think about this being used in very different circumstances to the previous two studies that I presented with autologous CAR T-cell therapy. So as Reuben mentioned, there are many benefits to using an allogeneic therapy, but we do need to get more and more of this data and more patients treated to better understand what the outcomes are going to be. So in terms of the real takeaway from this study, this is an off-the-shelf type therapy used in lupus. It does show some potential, but many patients need to be treated, and much longer-term follow-up is needed to see if this is going to be as effective, building on the data that we know from the treatment of blood cancers with CAR-NK cell therapy. But there will now be discussions and decisions we need to make as we are all approached about many of these trials as to what type of cellular therapy we're going to be looking at. Is it going to be allogeneic versus autologous? Is it going to be CAR T or CAR NK? And also, as Reuben mentioned, we have these bispecific antibodies as well. So these are all things that we are being approached about. What we find in terms of whether they're effective and how we pick these trials is very, very difficult, and we still have too limited data to make any strong recommendations on. This is an interesting piece of data that Marc very kindly shared with me from a recent publication in Annals of Rheumatic Diseases, looking at dual targeting of CAR T-cell therapy. And this was hinted to in the earlier talk. And this is a phase 1 open label study of a combined BCMA and CD19 directed autologous CAR T-cell compound, so CAR T-cell therapy in patients with lupus nephritis. As previously, the endpoints are very much safety-based, but the secondary endpoint was efficacy, and that was based on a SLEDAI score, which is presented in the data here. So in terms of evaluating this therapy, it is a combination of CD19, which is expressed on B cells, but also BCMA, which is expressed on long-lived plasma cells, which may be one of the key drivers of lupus and the key reasons for non-response to B-cell targeting therapy alone. So that was the reasoning for this study. Interestingly, B-cell count recovered after 6 months, but all patients had a reduction in their immunoglobulins, and that's of G, A, and M, and several of the patients also required supplements for hypogammaglobulinemia. The data here again shows that many patients had proliferative lupus nephritis with multiple concurrent therapies in the past, and what you can see is a general trend down of their SLEDAI happening relatively quickly. But again, it's important to look at patient 12, where they started with a SLEDAI score of 16. At 3 months, it was 10, but it was only at 4 months that came down to 4. So patients are having variable responses here. We should not be guaranteeing that our patients will be getting SLEDAIs of 0 at 3 months, as was seen in the initial open label data that was presented from Germany. But this gives us hope that many patients will respond to these types of therapies. So the headline from this study is really that dual targeting of antigens on B cells and plasma cells may be promising, but the trade-off here is probably the risk of immunosuppression and particularly hypogammaglobulinemia. So it's about that tightrope as we think about efficacy and safety. The study that I just presented with us combined CAR against BCMA and CD19. It's also shown some very nice data at a histological level in renal tissue. And what you can see here is in one patient where the follow-up sample showed an improvement in the immune deposits and histological improvement, which is one of the suggestions as to why these therapies may have a benefit over monoclonal antibodies in terms of tissue penetrance. And so I think this is really very interesting, and really it speaks to the point that we need to get much better translational data out of these studies rather than just looking at the clinical endpoints. And to bring up the next part of my talk, I thought I would kind of challenge where we were currently, and that's look at clinical trial design. And I think that many of the clinical trials that we're all being approached about and thinking about are on the basis of those first 5 patients treated in Germany, where you have patients who have exhausted many treatment options, who have severe and refractory and active disease with high background burden of immunosuppression. And it seems that many clinical trials have spun out on the basis of that. And so I would just like to briefly talk a little bit about who we should be including in these studies. So patients with an active disease process seems to be what many people say. This is true for trials, but does it impact safety? Taking patients at their sickest and then giving them a therapy that comes with risk. Is this the best patient to be treating? How do we taper immunosuppressive therapy before apheresis in autologous CAR T-cell therapy if someone is very sick and using high background medication? Also, how long is the manufacturing process? And it's important that it was highlighted that this time has come down, but clearly you don't want patients on substandard therapy for long periods of time whilst waiting for therapy to be brought in. And at a biological level, how functional are autologous CAR T cells if someone has established disease that's active and on high levels of background therapy? So we need to think more carefully about how we identify patients who may be of high risk of poor outcome and potentially catch those patients earlier. So there's lots of work that needs to be done here in terms of thinking of patients who are an at-risk group, not waiting them to get really sick to the point that they may have difficulty going into a trial. We need to do more studies about concurrent background therapy and whether we can continue some of this. And this is some of the work that Reuben and I have been funded to look into. And we need much better preclinical data to say which patients and what time and what type of T cells may be effective in treating patients and how much does disease activity impact on this. I would then argue that we need to think about patients who have a B-cell mediated disease, but this raises the question of which target, and it's CD19, CD20, BCMA, and again, the jury is very much out here. In which patients do we know that their B cells is driving their disease? You don't want to give this therapy to patients where perhaps there is a different pathway, and obviously with interferon blockade now becoming available, you don't want to target patients with disease that is not driven by B cells and not get a response. And I think this is really important when we think about the long-term data of patients who may not respond quite so well. And we need to think about what we mean by a durable response. People use this term immune reset. What does that mean? You're clearly not wiping the slate clean. And how long do we want patients to have a recovery for us to consider this a worthwhile therapy? So to solve this, we need data in terms of efficacy and safety. That's going to tell us where we go. We need to do a larger amount of preclinical work so that we can tailor treatment and move more towards precision medicine with B-cell targeting therapies in those that need it. And we need this long-term follow-up. I think that this is really going to be whether this is something we're using in the future. It will be based on the length of response and the safety of these therapies. And I just like to point out that this is something that we often discuss as patients who need it. So who are the patients who need CAR T-cell therapy? And I would say, well, who is going to come to harm and have no other options left? We don't want to overtreat patients where perhaps there is another therapy that is going to be easier, safer, cheaper, and more effective for them. And again, defining those patients remains a challenge at present. We don't tend to have a standardized definition of what refractory disease is or highly active disease is. We could base it on a SLEDAI score or a BILAG score, but many of those clinical trials are based in the biologic language. And do we need to think about different definitions for patients coming into these studies if we do define that refractory and severe disease is what we're looking at? Which patients are able to feasibly undergo treatment, I think is hugely important. And perhaps this is the most important thing. Many of our patients with lupus will not be able to take 10 days off work to come into hospital without pay, without being able to support their family to receive this therapy. We need to think about ways that the patients who need this therapy, if it is truly going to be a long-term effective therapy, are able to get it in a much more streamlined fashion than what we're currently doing. And I fully support that we should copy everything hematology are doing, but we do need to think about ways that we can perhaps deliver this to a very different population. So in terms of solutions, we need to think of a better consensus of who and how and when we treat. We need to move closer to getting this therapy more ambulatory. And I think the closer this comes to the standard biologic therapy, it's a big ambition, but I think if you do get closer to that, it's going to be easier to deliver. And we may need to think about better ways of remotely monitoring patients for adverse events without them being in hospital and with allowing them to perhaps function something closer to their normal day-to-day. And just finally, we need to think about endpoints. So LLDAS, we know that that was used in many cases of clinical trials. Does this go far enough? Are we satisfied with patients achieving LLDAS after treatment? I would argue the question is more, how long do we want patients in this state for? DORIS complete remission, is it too difficult? And as I mentioned, that's not been used in many of the biologic studies because it is quite a stringent endpoint. But does that mean we should give up on it? I would argue perhaps not. And do we need better endpoints in terms of how we can tailor this therapy for certain patients? And I was speaking about this recently with some of our trainees, showing that if this patient went into a clinical trial, you would see that their SLEDAI did improve. They would have an SRI-4 response, but clearly they had persistently active disease for a long period of time and just happened to tip into the successful result of the trial on their 12th month. In comparison, this patient would be seen as not effective if we were using an SRI-4, even though they'd had clearly a longer period of time with a lower SLEDAI score. And I think we need to think about what time we put these results in terms of this is a course of patients, and very similar to some of the patients we see in clinic. We record their disease activity here at baseline, where we define them to have high disease activity. We may then follow them up 6 months later, where we say it's no better, but actually did have a period of recovery that had worn off. And then we're basing the results of the study on how they are at 12 months, that perhaps is not covering what happened for them in the middle of that period of time. And so how we capture this is going to be really important for the health economics of if this therapy is to be used routinely in clinical care. So in my conclusion, I think we need to think about where we want to use this therapy if it was to come into clinical practice. And we need to think about that outside of clinical trials. Severe refractory active disease is fine, but we need to think about how we may wish to deliver this to our patients if it was available in the future. We need to design novel ways to use this therapy and perhaps move away from copying the current methods in hematology. I definitely think we need to up our game with translational research here to find out why are patients responding, and most importantly, in patients who relapse, what is it that is causing their relapse, because this is something we can't often see in clinical practice. And we really need to focus on the right patient at the right time and the right mode of action of the therapy. And that goes beyond just thinking about CAR T-cell therapies, but perhaps more broadly for lupus therapies undergoing investigation. We need to move towards a faster delivery of this treatment to get patients treated as quickly as possible. And that may mean looking at apheresis, manufacturing time, and safe and effective discharge to get patients out of hospital quicker following this therapy. And this will require a change in regulations. So this is where we currently are, just to remind you of where we may look to improve things. Do we need leukapheresis? Can we do without this? Are there other ways of getting cells? And clearly allergy would be a way around this. Bridging therapy, absolutely important. What do we do for patients before, when they've got active lupus? What is stable? What is the impact of this on autologous CAR T-cell therapy? Do we need lymphodepletion? And I would certainly argue yes, based on what the hematology literature says, but we're going to need to find out whether we can modify this in any way. And can we get patients out of hospital quicker to potentially mean that there's less impact on the life of our typically quite young patients who may be warranting this therapy? So Reuben and I, as I mentioned, have been awarded some funding from the Lupus Research Alliance to try and look at this in the lab here at King's, and we're going to be hopefully kicking this project off relatively soon to answer some of those questions that may allow us to deliver this therapy quicker. And I would just like to conclude by saying we have a long way to go before we work out whether this therapy may potentially make its way to clinical care. And I think a lot of that is going to be based on the long-term safety and efficacy data. If this is long-term effective and very, very safe, you can see a way for it through. If it's going to be laborious, labor-intensive, high risk, and only for very sick patients, then we may be using it in smaller number of cases, and we definitely need this trial data to come out and tell us who may be needing it. We need to carefully design the clinical trials and not just think this patient is sick and refractory, but maybe we could perhaps think more preemptively in patients who are less unwell. This is a huge translational opportunity, as I mentioned earlier. Even in non-responders and relapses, we will find out a lot more about what is driving the disease in our patients after this strong B-cell depletion therapy. And if I had to pick a winner, I wouldn't think it's going to be the cheapest, the safest, or the one with the longest efficacy. I imagine it's probably going to be the one that becomes easiest to deliver in the future. And with that, I think we need to think very carefully about where we would expect this therapy to land in 10 years' time and start working on things from there. And with that, I will bring my talk to a close. Thanks very much.
Thank you very much, Chris. That's fantastic. And I think your first reaction is to hope that we found a magic bullet that'll treat the most difficult lupus. But I think, as you've shown us, there is even really good treatments have an awful lot of dimensions to think about in how to use them, which is a good link onto our next speaker. So now Marc Scherlinger from Strasbourg University in France is going to talk about how CAR T therapies might look actually in clinical practice, not just in trials. Over to you.
Thank you, Ed. Thank you, Chris and Ruben, for your wonderful talk. So I've had a very difficult thematic to cover, which is how do we integrate these CAR therapies into lupus treatment. So as you know, you will probably not have all the answer to this question, but I'm sure that in the next 10 years, we'll have very interesting research and discussion together to better tailor the treatment for patients. My disclosures. So during my talk, I will address efficacy consideration, safety consideration, and then point to future challenges and direction that we may think of in SLE. So in the last 50 years, we've had a better understanding in the pathogenesis of lupus. We all know that autoantibodies and therefore B cells are a key feature in lupus. And despite the fact that also T cells and innate immune cells such as platelets, neutrophils, and so on are involved, we do believe that B cells have a central role in SLE. And their maturation comes with either a follicular and extrafollicular way. And there is no additional evidence, accumulating evidence showing that if we can disrupt these B cells, it might altogether break the vicious circle that we have in SLE where apoptotic cells release nucleic acid, forming immune complexes, activating type 1 signature interferon. And interestingly, when we do disrupt B cells, when we treat the patient with CAR T cell, we see a decrease or an erasing of the interferon signature. So this B cell targeting seems to have a very nice effect. And these are data from a Gerchet Center. So as he demonstrated very well, using CAR T cell, you completely deplete the B cells in the tissue, in the of course in the periphery, but also in the tissue. And this is lymph node tissue on the left, despite in comparison to rituximab, where you could see some remaining B cell in the tissue after treatment. So this is really a next level B cell depletion. And the other thing very interesting to my mind is the GC disruption that you can have with CAR T cell. You have a complete disruption of the B cell maturation, and so a stopping of the production of novel autoreactive B cells that might approach this kind of immune reset that we've been talking about a little. That is maybe more difficult to access that we once thought. So which patient may benefit from this therapy? And I think we could spend an entire webinar just discussing on this thing. This aspect, I think it's very challenging, but the main thing we want to remind is as lupus physicians that we want our active patient to become patients for the longest time possible, ideally without corticosteroids, and ideally, even more ideally, without any other treatment. And when you discuss with patients about what they want for the disease, they don't tell you, I want a new drug, or I want to be better, as they want to be cured. And that's probably the thing we want to aspire for a patient in 10 years for now, as Chris was mentioning. So who have we treated so far? Chris has discussed this already, mainly treatment refractory patient, whoever they are, because we have no clear definition of what is a treatment refractory patient. One thing that I think is important to mention is we could also classify as refractory patient who do not take their treatment, which are non-adherent, which is a really important issue in lupus. In some lupus patients. And of course, corticosteroid dependence is a huge problem, and one that leads to chronic damage that we want to avoid. So in the future, probably the CAR T cell might come closer to the diagnosis or used in less severe patients. I want to remind you this study, this recent study showing that the damage in lupus, it can occur very rapidly after diagnosis, and it's really cumulative based on the cumulative corticosteroids dose. So at some point, we will ask the question when these treatments are safer with better data, better efficacy and safety data, whether we can use them in patients without severe organ involvement, but with multiple spheres, corticosteroid dependence, or very severe alteration of their quality of life. And I think for the future, of course, we do need more long-term data, but we might also need some medical economical analysis to know if curing even a non-very severe patient, but that has flare every few months is better than just using regular treatment. That will be, I think, a question for the future. So we've discussed data for Georg Schett's study from his experience in Erlangen, and this is the latest slide. He showed that EULAR, for those who are not able to see it. So he has treated so far 27 lupus patients and a few other patients in other diseases. And I want you to stress on one point is that we have seen some relapse in patients. So some patients do not respond entirely, as Chris showed in some trials, but also some patients have relapsed after anti-CD19 CAR T cell. And I think one point to consider, and it is very conceptual, I don't have clear data to show, is that these two patients did not have negativation of their autoantibodies, or at least some of their autoantibodies are showing that with this treatment, we might not, at least in some patients, access this immune reset that we've been talking about. So I wanted to discuss one thing about which cell we want to target in lupus patient. I think it's a very, very important conceptual thing to think about. Most pathogenic B cells in lupus that have been described are plasmablast and double negative B cells that do express CD19, but in some subset of patients, some other autoantibodies are found, and these are for example, anti-Ro60 antibodies in lupus, SCL70s in scleroderma, and these autoantibodies are produced by long-lived plasma cells that do not express CD19. And I'm not saying, so for example, the lupus patient that relapsed in Georg Schett's study had positive Ro60 antibody that did not vanish with treatment. So I'm not saying the Ro60 are pathogenic and are responsible for the relapse. I'm just saying that this proves that we do not have complete immune reset, and we might need to identify in which lupus patient there is autoreactive long-lived plasma cells that do not express CD19. Therefore, in this patient, we may use stronger or other targets such as BCMA or dual CD19 BCMA targeting. And I think that's a very important thing to think about for the future. So about these relapse patients, I wanted to just discuss this very recent paper from 2 months ago from Georg Schett again. He shared this experience for this patient who relapsed. So this is the patient with inflammatory myositis. He did not publish the SLE patient. But the first interesting thing is that when you retreat the patient with the same CD19 CAR T cell, actually nothing happens. There's no expansion of the CAR, and there's no B cell depletion. And he has shown that beautifully in this paper. I will not have the time to show you the data, but that there is a B and T cell immune response from the host against the CAR, preventing retreatment. And Therefore, the immune system clearly destroyed the CAR T cell if you try to retreat. However, what he did is that he retreated the patient with an anti-BCMA CAR T, and that actually rescued the patient. So you could see after treatment a B cell depletion and clear improvements in disease activity in this myositis patient. Another warning that I think is very interesting, that in this panel here, you can see that even with BCMA treatment, there is a decrease in the titer of anti-GO1 antibody, but there was no complete erasing of the autoantibody, suggesting that even with this BCMA CAR T, there's no total autoimmune repertoire visit in this patient. So we'll need some more long-term data to know what happens. So B-cell depleting therapies and CAR T-cell therapy are now well established in the armamentarium, even if they are currently mostly used in clinical trial. And I think we do need to continue this trial to think, as Chris beautifully discussed, at good design, at good patient selection to make the most of this exciting therapy. We'll have to, as I said before, maybe identify which target we use in which patient. Maybe we'll need to also target BCMA in patients where we have evidence of plasma cells, autoreactive plasma cell involvement, but it is really conceptual, and I think in the next 10 years we'll have wonderful data to understand this. And one question that was asked for me is, what about treatment, add-on therapy to prevent relapse? For example, hydroxychloroquine and belimumab. So in the trial from Georg Schett, all the patients stopped all treatment, but but some patients did relapse, and in other trials, some patients did not go into a complete remission. So I think it's reasonable to continue hydroxychloroquine while the patient is not in complete remission. And belimumab is clearly a drug that might be interesting because, as you know, when you deplete the B cells, there's a high increase in serric BAFF, which is targeted by belimumab, and belimumab has been tried together with rituximab, although the result of this trial were not so convincing. I think that conceptually it could be an interesting way in patients that do not respond completely to CD19 CAR T therapy. So what about what's next? And we've discussed about this already, so I'll go pretty fast about off-the-shelf therapies that are might be the future. I think the future is that we, as Chris said, and Reuben also, we need really to have easier to use treatment because the first generation CAR T cell that we used in the clinics are too cumbersome to use, because even 10 days is not a lot. I think the patient we treated, he was like almost 4 weeks in the hospital. It's really too long. So we need to make that better, and off-the-shelf therapy might help. Of course, they have some advantages. They are rapidly available. They might not, there is no long-term persistence of T cell, which is a huge importance for safety. I'll talk about that a little later. And we might decreased or no lymphodepletion with this therapy. It's not that clear. We can talk a little about that. Final thing is that it may be less costly, and it is just a little pipeline from a presentation that was shown at EULAR, and it is a private company that showed this data, but they argued that it was $3,000 a dose of their, it was iPSC-derived CAR T cells. So this new kind of therapy might decrease the cost of CAR T cells. So just a few data on off-the-shelf CAR we've seen some so far. The first thing that has been said before is that you need repeat dosing. It just it's not just a one shot as with autogenic CD19 CAR T cell. The second thing is that we need to see with different studies, but there might be a lesser clinical response compared to what we can see with autogenic CAR T cell, but we need other data. And finally, I wanted to show this very recent data for EULAR. It was the same company with a $3,000 shot iPSC CAR T. They tried to treat a patient without lymphodepletion. And what they could see after 6 months, there was some clinical improvement, as you can see on the left part of the slide with the SLEDAI-2K. However, there was no complete B-cell depletion, meaning that maybe the CAR was not able to completely do its job. So maybe lymphodepletion will be still necessary. So of course, we need for more long-term efficacy data. I would like to go very fast about safety considerations. So we've discussed about CRS, ICANS. In autoimmune disease, these are mostly grade 2 or below, because as Reuben mentioned, these cytokine release syndrome are based on the quantity of target that you destroy. And in autoimmune patients, they have normal count of B cell compared to a patient with lymphoma, for example. So this is often not a problem. The cytopenias and infection are mostly benign. However, I want to stress that one patient in a clinical trial study did die of an invasive pneumococcal infection. This patient was not vaccinated prior to the trial, but so these are immunosuppressive drugs, and we still should be careful. And there is low risk of hypogamma with CD19 targeting, which is not the same for BCMA. For hematological neoplasia, I will briefly talk about this. This has not been yet reported in patients with autoimmune disease, but it's still possible. And one final thing that is important is potential pregnancies. We're talking about young female patients, often female patients that are treated with cellular therapy, modified genetically, and will need to know if this can have an impact on this future pregnancy. There has been one reported pregnancy in a BMS trial, and the children was born without any issues. So this is a good signal, but we need more safety, long-term safety data. For the risk on lymphoma, you probably heard that in patients with hematologic cancers, there's been a few cases, around 35, of T-cell lymphomas secondary to CAR T therapy. And I wanted to show this example that is really emblematic. They showed here that actually the CAR sequence inserted inside P53 tumor gene suppressor gene and led to its invalidation. And quickly the clone with this deletion became the majority of circulating cell, and the patient developed lymphoma. So this is something that can happen, and there are ways to prevent it. And I think there's a lot of work about this, such as integrating the CAR sequence in a safe DNA spot, placing a kill switch in the CAR, or make the CAR express targetable protein, and therefore we could target and destroy the CAR if adverse event was happening. So this is things in development, but we definitely need to make this therapy safe for the patient. For the future direction, we need, of course, as all my colleagues have already said, more data. And here, a figure showing all the clinical trial in different diseases. There are more than 25 ongoing. So it's a really rapidly evolving field, a very exciting field. And I think Chris already mentioned the question. I wanted to finish my talk with a few slides on future direction. I want to stress that CAR is only a tool. Basically, it's like monoclonal antibody at the time. We can make whatever we can think of, and I think we can make a lot with CAR, where we can change the structures, change the target, change the cells we use. And future direction are currently looking at that. You can, for example, think at treating directly the patient with a vector. So the CAR insertion in the T cell would happen in vivo directly. So this has not been yet done in human, but it's under development. And as Reuben has discussed briefly, we can think about CAR with 2A to target antigen-specific B cells. However, one big issue for that is that SLE has many autoantigen, and I think it would be very challenging to develop one of such CAR. So I wanted to show a very interesting strategy that is being developed by Marc Scherlinger in the US. So he's using the fact that most autoantibodies such as dsDNA, SSA, and so on use the same heavy chain idiotype, 9G4. And actually, he developed a CAR that is not specific of one autoantigen, but of this idiotype, this heavy chain idiotype. And so this is in vitro data, but using human cells. You can see that with classical CD19 CAR T cell, you destroy all the B cell. However, with this construct, you only destroy the B cell that express this heavy chain, and these are mostly autoreactive B cells. So I think this is a very elegant strategy, and we might use in the future. And actually, I'm finishing with the same slide as Reuben, and we did not talk about that. So I think we are on the same idea here, is that can CAR therapy outlive antibody-based therapy if these therapies can do the same? And I think it's a very odd question for the field with T-cell engager that are many types, and there will be a lot of future works in the future to better understand how they can be involved in the treatment of our patients. Thank you very much.
Thanks very much, Marc. So that's 3 brilliant presentations. I've already learned quite a lot about this, I think, and it's time for us to ask some questions. I can see a couple of them coming in, but I've just got to start with one of my own, actually, that I was thinking on a couple of these presentations. Maybe I'll ask it to Chris first, and then the others can come in. I think you alluded to this a bit, is that these trials are all reporting SLEDAI scores and LLDAS. These are quite old outcome measures when CAR T therapy was like science fiction. Are they really capturing what we're trying to achieve with this? Are we doing CAR T to get a better SLEDAI score, or have we got something else in our ambitions?
Yeah, it's thanks very much for the question, Ed. Obviously, being in the UK, being part of BILAG, obviously a question on SLEDAI is going to tempt me down. The BILAG may cover more things than the SLEDAI, but I think that perhaps we do need to think about things in a very different way in terms of the cost benefit of this if it comes through. Does a SLEDAI score or a BILAG of D's and E's, does a SLEDAI score of 0 really mean that patient is feeling better, functioning better, and doing better? And we're doing a little bit of work at this at the moment where we're looking at patient response to treatment in terms of our metrics versus whether the patient actually feels better and is doing better. And I think perhaps we don't capture some of that in SLEDAI. And I think that is one of the big challenges. We've been having some discussions locally about, are there better ways in lupus trials in general of capturing improvements that may be meaningful to patients? So, for example, the amount of time that the patient is walking, how much of their time is at work, how much of their time is spent doing leisure activities, and how much of their time is spent in bed and not able to do much. And I think that when we think about SLEDAI and BILAG as well, we're very used to doing it in clinical trials or in clinic where the patient is sat in front of us and we make an objective assessment of how that person is doing within 30 to 40 minutes. And we don't really see what they're doing at home, how they are with their family. And so I think that we really do need to demonstrate that there are other forms of efficacy beyond just simply switching off symptoms and normalizing serology. to really show that this is a transformative treatment. And I think that perhaps now is the time to think about that. It would be very nice if we can present some phase 3 data, perhaps one day, showing that the SLEDAI is 0 in the vast proportion of our patients, or the BILAG scores have all completely normalized. But I think the thing that might capture perhaps patients and regulators' attention a bit more is, how is that patient functioning? Are they walking 3 times the distance they did before? Are they reporting improved health-related quality of life? Are they actually able to get back to work and spend time with their family? And I think that Reuben and I have discussed this as well, in terms of when is the time to get that data captured. I'd perhaps argue we need to start doing some of that data capture now, because I think this will all be part of the assessment from regulators when they think about these therapies potentially being used in clinical practice.
Yeah. I mean, one thing it's like the PRO response is important. The other thing I see a lot, comes up a lot when people talk about I take the point that the responses vary a bit from person to person, but what comes up a lot is, I was off my other therapies. And I just thought that's a very insightful comment, that was one of the best achievements. That I think I often say these days about, we talk about lupus disease activity, we talk about damage like scars in skin or kidneys or something, but there's this kind of social damage, isn't there, which what it's done to your life, some of which might be a bit hard to reverse if you haven't had the family you thought you were going to have or something like that. But it's that, isn't it? That's what we're trying to get at, is this a different thing, not just response, not just disease activity. Okay, and then another question. I think this is someone's asked maybe I'll ask this one to Marc, and again let the others come in. This is a really simple question, but I think it opens up a really important point. How fast does this treatment work in severely unwell patients? So is it an emergency treatment?
Thank you for the question. It's very difficult to say, because we do use lymphodepleting therapy just before the treatment, and this therapy with cyclophosphamide and fludarabine does have an effect on the patient. So actually, very rapidly we see an effect, but it's difficult to know if it's a B-cell mediated effect or not.
Yeah.
But usually, it goes very fast, but probably in part with the lymphodepletion therapy.
Yeah.
However, in patient who, for example, in the relapse patient from Gauchet, we receive lymphodepleting therapy and CAR retreatment, which didn't work. The patient was not better. So it's not only the lymphodepleting therapy. So it's hard to say more.
It's like, so yeah, that's what I thought. I thought actually that's such an interesting question, because if it's an emergency and someone's really ill in hospital, it's actually other treatments that initially sort things out, isn't it? Because it takes time you described that some treatments are faster to manufacture and administer than others, but all the same, it's gonna take time, and it's other treatments that save the day in the emergency. This is not about that. It's about changing things long term, isn't it? Is more what we're trying to do here.
Yeah, definitely. And I think some trials are actually trying to change a little of that. They allow, for example, a GC pulse and so on before CAR-T, because you don't want to let your patient highly active for 2-3 weeks before treatment. And I think, it's something to take into account, because we are looking at long term.
Yeah. Okay, and then there's a question that's just come in here for Reuben specifically, is, since CD19 CAR-T and T-cell engagers have been around for longer in hematology oncology, be interested to hear your experience about how similar or different the efficacy and safety are between these two modalities. And is that going to be the same trade-off in autoimmunity?
Yeah, so we've had experience with blinatumomab, the CD19 bispecific antibody in ALL for some time now, and then in the last 3 years we've had a whole array of different bites for cancers. But what I will say is that whilst the response rates are pretty comparable to CAR T cells, the durability of the responses are often not. So obviously there's not been any head-to-head comparisons per se, but just to give you an example, in myeloma, the anti-BCMA bites gives you somewhere between 12 to 18 months of remission. The best CAR T-cell products for myeloma directed against BCMA will give you 3 years remission. So that's the difference in terms of durability of response. In terms of safety profile, yes, I mean the T cell engagers in terms in terms of CRS and neurotoxicity, it's very much lower than with CAR T cells. But there are issues with infections, so because they're being redosed, you're continuously depleting your B cell compartment or your plasma cell compartment. And so you have to continuously supplement them with intravenous immunoglobulins, for instance. So there's a trade-off there. You might have less toxicity initially, but then you have probably more ongoing toxicity in terms of infections unless you really proactively give them ongoing immunoglobulins. And that's also then a issue for patients who have to keep coming in every single month, whereas with CAR T cells, perhaps they're on immunoglobulins for a few months and then they come off it.
And I think that really speaks to what Marc was saying about is this disease all starting from B cells and that just change them and we'll reset it? Or if there's other aspects involved in immunity, which we know there are, of course, then if we're talking about repeat therapy, it's a completely different proposition. Again, somebody else has asked, like, should everybody have B cells and plasma cells targeted together? And I looked at it and thought, well, if it's one off, yes. If I have to do it lots of times, maybe not. Yeah. Okay, great, thanks. Okay, a question. Who shall I ask this one to? Perhaps this is one actually again for you, Reuben. There's lots of chatter about why the Erlangen experience, specifically in the Castle study, appears to have better efficacy outcomes in SLE than other trials. It appears that for the Castle study, the CAR T cells are manufactured in-house, not frozen prior to infusion, whereas all the other trials did have that. Do the panel think that might be important?
Okay, I mean, I'll just purely talk from a CAR T cell point of view. I mean, we have plenty of experience of freezing CAR products and most of the commercial products are all frozen products that you have to thaw out and infuse. But there are some academic centers that do in-house manufacturing where fresh cells can be given to patients. When you look at the viability of cells, after freeze thawing, yes, it is a bit reduced compared to cells that are given fresh. But I think overall, I don't think the data really supports a significant improvement in outcomes with fresh versus frozen. Yeah. And with fresh cells, it opens it up to a whole range of other issues in terms of quality control, etc., which you have better control of quality when you've got a frozen product than you have. So I don't know specifically why the Erlangen experience is better, but
might be,
it could well be a patient selection issue. I don't know because it's
so Chris, Marc, any thoughts on that?
Yeah, I
it's
think
definitely please, Chris, please.
Marc, you go ahead.
Yeah, it's a very difficult question. Obviously, I completely agree with Reuben that freezing might not be the response. Maybe it's the patient selection, and maybe it is where a little less refractory patient than in the study. And also, as Chris mentioned, this was most of the patients were really a recent lupus, and maybe they did not have time to expand their autoimmune repertoire, as we know happens in lupus and other autoimmune disease, and to really have more long-term autoimmunity. That might be one point, but what you think, Chris?
I think from my perspective, you kind of hit the nail on the head there. We're taking T cells, if we're doing it autologous, from patients who have an active immunological problem that is severe and refractory. Those cells are likely to be very different depending on which time point you take patients and what their background therapy is, which is where I think in the clinical trials it gets slightly tricky rather than just open selection of patients. So I think we'll know more about that, and that's perhaps why I put in my presentation that the challenge to everyone now is let's think perhaps more laterally, and are there things about the T cells of patients that are different, that are generating this difference in response. And I think we need to learn a lot more translationally to see where this variability may be coming from.
Yeah, and then and the other thing is are these different types of lupus patients like pathogenically different in their backgrounds? I think you alluded to, Chris, in your talk, and you did, Mark, as well. And there's someone's asked a question, which is, do we think that if patients were the age of the patient might be important because of the thymus involution? And that's an interesting thought. I'd also written down germinal center disruption. How important is that? 'Cause some B cells are extrafollicular, aren't they? Perhaps I'll turn to Mark to comment on those.
Yeah, I don't think that's very important. And probably if we disrupt the follicular maturation, we probably also disrupt the extrafollicular maturation. Actually, that's something we are trying to do in lupus mice, to see what happens in vivo in the tissue for both CAR T cell and bispecific antibodies, and that's really important question for the field. So yeah, I think it's very important, because if you destroy this vicious cycle, then everything seems to go better, including the interferon signature, as I mentioned.
Yeah, right. And I what I've been thinking about that is, okay, we know that some lupus is genetically due to something completely nothing to do with B cells, like clearance of DNA or TLR pathways or something like that. And it's like, how could you cure that? And I thought, well, you can't. I know you can't, but it takes time to get lupus, doesn't it? It takes years
Yes.
to go from the first immune abnormalities to symptoms of lupus, and maybe that's what's happening. You put someone so far back down the pathway.
Yeah, exactly. And for this patient, it would be a good thing to use treatment to prevent relapse. For example, hydroxychloroquine at least, but also not so dangerous immunosuppressive drugs such as belimumab.
Yeah. And most people who have preclinical phase of lupus don't end up with lupus.
Yeah.
So can
Exactly.
homeostasis come back in some way?
I think just to add to that very briefly, I think it's this interesting thing of, as you mentioned, patients have probably had lupus for a very long time. So even if we take blood from them on the day we diagnose them, we don't know what was happening when the disease started. And I think this is where the translational opportunity with the non-response or those relapses are huge, where you'll have a whole repertoire of biobank samples that can inform us more towards what happens at the start of the disease following the therapy.
Which takes us probably to what it's going to have to be our last question. But does that all of that mean that this should be a treatment that's positioned a lot earlier, rather than waiting to fail everything?
I have a question.
Oh yeah, okay.
I have a question for Reuben. So Reuben, I think in your talk you discussed about anti-G-CSF monoclonal antibody in CRS. I wanted to know when you do use it, and have you also considered anti-interferon gamma monoclonal antibody for CRS?
Anti-GM-CSF, yeah. Well, we haven't personally used it, but there are trials ongoing using it, and there's been some data suggesting that it does work. And it's generally used in cases of CRS that's refractory to tocilizumab and steroids. Now, in general, we don't get those cases anymore. We go in early, grade 1, before we were treating at grade 3. So I don't think we really get to the stage where we need those alternative agents, even in the cancer indication. But every now and again, you get to grade 3 CRS where you're trying to throw in whatever you can. So I've never used anti-GM-CSF antibody myself. In terms of interferon gamma, I've heard of odd cases where that's been tried, but again, I don't think it's necessary in most cases. Yeah.
And actually, Reuben, there's one other one I think which is for you, but actually, great question is, can we speculate that the patients who have underlying mutations in cancer-associated genes are the ones who are going to be susceptible to the CAR-associated lymphomas?
Yeah, I think that's fair to say that's true. Now, I must say the secondary T-cell lymphomas that were reported, I mean, the number of cases are very low indeed. There are only about 30 odd cases initially reported, and that's out of 40,000 patients that have received the CAR product, And these are all patients with pre-existing cancers who've had other therapies that also leads to secondary hematological malignancies, And in some of the cases, they have actually discovered specific mutational abnormalities that probably predispose them to the T-cell lymphoma. So I know there was a worry when this was first reported that this could be a more widespread event, and that would be certainly a no-go then for introducing CARs into non-cancerous conditions like lupus. But I think the field can be reassured it's a very rare event, you know.
Yeah, and I suspect what the questioner is thinking of, it's thinking about is that might actually be much less of an issue in autoimmunity than where they haven't already demonstrated themselves to have those problems. Okay, and that's a great place to end. It would be great to talk for longer, but it's been an absolutely fascinating discussion. So thank you everyone to all of our speakers, and thank you everyone to attending for attending. Just a couple of points to finish up with for our listeners. There's an evaluation form that's going to come up at the end of this. We do really listen to your feedback when we're thinking about what we're going to put on Lupus Forum in future. So please do let us know what you found useful or what you'd like to see more of. And there's a good chance we'll do it and we'll respond to it. Also, as always, this live streamed webinar is going to be available on our YouTube channel on Lupus Forum. So you or your colleagues who've missed it will be able to see that. And I'll just finish up again by saying thank you to BMS for supporting this program with an educational grant, although they didn't have any influence on the content of the presentations. Okay, we'll end it there. Thanks. Bye.
Thank you.